first one that we've talked about that's not actually part of the cardinal lines. The back line, the superficial front line, the lateral lines, those make us the cardinal lines. This one kind of takes us on a completely different path. And as soon as we start looking at the different structures, the different tissues involved in the in the spiral line, we can see that it doesn't look exactly like any of the other, or it doesn't look like the cardinal lines. Like we talked about on Tuesday, the cardinal lines, they start at the head, end at the feet, start at the feet, end at the head, run in a very straight path, a very linear path from the top to the bottom. The lateral line kind of makes a series of X's once it gets up to the pelvis, but it still travels in a very north-south type direction. Spiral line, we take this entire journey on the spiral line and we either go from the mastoid process on the left side to the occiput on the right, or the mastoid process on the left side to the occiput on the left. So we take this giant journey around the body, we wrap the body several times, and we end up almost right back where we start. So it is a little bit unique in that aspect because it doesn't start at the top and end at the bottom. It's a lot, and because of that, the forces that it can exert in regards to what it does for rotation and dissociation and how it contributes to rotation and dissociation from the neck all the way down into the ankle is very significant. It's kind of unique because it can generate both local rotations, but as well it can contribute systemically to dissociation. If we're just talking about the splenius capitis and cervicus up at the neck, if those are functioning, those muscles work kind of in isolation, they can generate cervical rotation. If we talk about the obliques, the external obliques and the internal obliques, we can generate spinal rotation. If we talk about the interaction of what's going on from the TFL down through the IT band, into the anterior tibialis, up through the peroneals, and the lateral hamstrings up into the ischial tuberosity and sacrum, that can generate rotation of the leg. So individually, the different areas, the upper, the middle, the lower part of the spiral line can contribute to local rotation. But at the same time, when the entire spiral line is working together, what that creates, because it changes where our sensory input's going, it changes where the trunk's oriented. Now we get in and start looking at a systemic type of rotation, which is a dissociation that we talked about before. So this line's a little bit unique because it contributes both to rotation of everything that's involved with, and systemically can have a heavy influence on dissociation. We talked about the lateral line a little bit, especially how it has that basket weave from the pelvis up. You can create a little bit of trunk rotation there, but that's about all you can get. You can get a little bit cervical rotation with that. Because the lateral line is so far from midline, it can contribute to those rotations. But when we talk about the superficial front and the superficial back line, because of how close they are to midline, and because of the orientation of their fibers, they really can't be that involved in creating a lot of purposeful rotation. We can't even have a discussion about dissociation with them. So anytime we're having a discussion about dissociation, superficial backline, superficial front line are off the table of discussion. They're not involved. When we start talking about dissociation, dissociation is all about the spiral line predominantly, and a little bit about the lateral line, and especially the lateral line from the pelvis up. Talked about these the other day. The only original component to the spiral line that it hasn't pirated from somewhere else are the rhomboids and the serratus. Everything else is a component of one of the other cardinal lines. From a bony anatomy standpoint, again, we're just talking about a lot of tissue in the spiral line, a lot of soft tissue in the spiral line, which means we're going to have a lot of connection points. So if we just think about these top three, the mastoid, the occiput, and transverse process of C1, C2, that's all very high up in the cervical spine. That's very high in the line. This area, not directly tied into the suboccipitals, but that's very close to the area of the suboccipitals. But it's not like the superficial backline because it doesn't include the suboccipitals. So it attaches in the same place, passes through in the same place, but because it doesn't have the suboccipitals as part of the line, this line's not tied into vision as like the superficial backline was. Everything else, medial scapular, lateral ribs, iliac crest, all the way down into, once again, we have the sacrum, the ischial tuberosity. We talked about those a couple times before. And then we finish up at the occipital ridge on the opposite side. Or on the same side. Not a lot of other tissues. We have the linea alba, the dividing line between the rectus. So when it grows from extensor or external oblique on one side to internal oblique on the other, it crosses there. We have the IT band. All the conversations we had about the IT band last week in regards to the lateral line, we could have that same discussion today with the spiral line. So everything that we said last week about the IT band and the importance of the IT band and the tie-in to the vastus lateralis, just go watch that one again. Look at those notes again. It's the exact same conversation. Spiral line can have that same kind of influence. It can have the same kind of impact on and from the IT band that it had in the lateral line. So the line doesn't really change that discussion. Sacrotuberous ligament, we talked about that one before in the superficial back line. Same thing. It transmits energy, transmits forces through there, and then we once again come up into the lumbosacral fascia, the fascia of the low back. This is the first line where we actually cross midline, and we cross midline at 4 different points. First place we cross midline is C7, T6, the lower cervical upper thoracic area, where we go from the splenius muscles down into the rhomboids. So that's our first point of crossing midline. Come around. Second point we cross midline is the linea alba to go from external obliques to the opposite external obliques. Then we stay all on one side until we get down to the foot. And then where the perineals and the anterior tibialis interact on the bottom of the foot, base of the first metatarsal, the cuneiform, we cross midline. Now it's not truly the body's midline, but it's a midline of the joint, midline of that limb. So when we're in single leg stance, that does become our midline. And then as we come back up, depending on what all's going on, we can cross midline that 4th time at the sacrotuberous ligament at the sacrum, where it goes up into the lumbosacral fascia on the opposite side. So we have 4 points that we cross midline. That hasn't happened before. If you remember back to when we talked about the nervous system, anytime from a nervous system standpoint we cross midline, we have static to the situation. Just because midline's a very set point for the nervous system. And here we have a line that crosses midline 4 times. So if we think about that, there is a considerable tie-in with that. The rules don't change. We can't talk about, when we're talking about the nervous system, we can't talk about how when we cross midline things get more challenging, and then have a line here where we have 4 times that we cross midline and don't have a similar discussion. When we get to the postural tie-in, where this posture ties in and where this posture develops, one of the things you'll notice is it's not early on. And it doesn't develop early on because of the complexity of this line, because of what it does in regards to crossing midline and what that does to the input to the central nervous system. Remember, for us to have any kind of controlled output or controlled behavior, we have to be able to process that input appropriately. We're getting input from a line that's all over the place. So because of that, we can't just start, we don't just intuitively get this input and be like, oh yeah, we got it, it's a spiral line, whoop-de-doo. We have to work it out. So because of that, we see the development of the cardinal lines first. We see the very linear flexion extension type motions, the lateral flexion type motions. Once again, we don't see that rotation, that dissociation happening until significantly later. So we don't see this line becoming very prominent until significantly later. The earliest point that we'll see anything with this line, the very earliest, and it's not even in the postural tie-in because I would question whether or not it's actually a true tie-in to this line, is when we start to see the segmental rolling from supine to prone. That transition from supine to prone. But, and why I say that, that's our first form of very inefficient locomotion to get from point A to point B. It connects one posture to another. We have dissociation in that. This line is all about dissociation. This line, since it's all about dissociation, it also ties in, this line has to also be about locomotion, getting from point A to point B, which is one of the reasons why we see it wrap the body the way that it does. So that as we're transitioning, we have systemic control of that dissociation, systemic control of the local rotations to tie to the more purposeful thing that we're trying to do, which is getting from point A to point B efficient. So we see it start to develop, we see it start to let us know that it's there and rolling. Why I don't think that we should formally consider that as the entry point into the postures is because the feet aren't on the ground and we don't have an anchor point. We're just going through the motions with that line. Now, once we get to crawling in quadruped, we have the same conversation, but now the feet are engaged in the ground. We're putting forces down into the ground. We're redirecting those forces. We now can talk about force transmission through this line. Two double helixes. So it's not like the DNA where there's spiraling double helixes, but we have actually opposing double helixes or mirror reflections of each other. They wrap the body, starts at the skull and ends at the skull. And because it ties in so intimately, because literally every other component of this line other than the rhomboids and the serratus are hijacked from other lines, it supports the other lines in their motions. Now, by itself, again, when this line's functioning and doing the things that this line is designed to do, we're having a discussion about dissociation of the locomotion. But because so many of the components of the spiral line are parts of other lines, when we're talking about those movements within the cardinal lines, the flexion, the extension, the lateral flexion, each direction, because of that intimate tie-in, and because of the crossover of those structures, what the spiral line is doing when we're going through those flexion, extension, lateral flexion type moments is supporting that. So that motion is as symmetrical as it can be based off of the situation at hand. It helps to control and make sure that the pelvis stays as level as it can based off of what's going on. The shoulders stay as level as the shoulders can based off of what's going on. Doesn't mean they're going to be perfectly level because we can have other things going on. But this line really helps to support and mediate those movements within, within our flexion and extension and our lateral flexions within those cardinal lines. Because of that, it helps to control motion within all of our planes of movement. It is a direct connection, a very influential direct connection between the foot and the pelvis, more so than even the lateral line. The lateral line, we went through the outside, looped in, caught the bottom of the foot. This one actually is pulling the foot up into the pelvis. Because of that, what it does from a knee tracking standpoint, if we're having any conversation about a valgus collapse, you're having a conversation about the spiral line. If you're having a conversation about patellar tracking, for whatever reason, whatever train of thought you buy into and believe, you're having a conversation about the spiral line. So we can't have a conversation about the position of the knee in regards to varus and valgus without including the spiral line. And then, again, just because of its path and lines of pull, it can either create local rotations or systemic dissociation. Creates rotation, creates dissociation. It controls the trunk and the leg, and it helps to prevent us from collapsing down. So every time we're walking, if we think about when we take a step down, all the forces are coming in this way. As soon as I'm in single leg stance, yeah, my left superficial back line, my right superficial, my left superficial back line, my left superficial front line, and my left lateral line kind of work to control this, but they control it in a very linear manner. Forces don't necessarily move in a controlled linear manner, especially if as I'm walking, I'm rotated this way, because now I'm opened up this way. When my foot hits the ground, everything's going to want to collapse over here. Well, there's not a line on the inside of the leg that supports that. The lateral line can a little bit, but it's, again, a very linear line. The body's not linear. So where the real control comes from in gait to prevent us from collapsing down to the ground comes from that spiral line. The spiral line is really what helps keep us from collapsing down to the ground every time we take a step, whether it's from a walking pace, a running pace, single leg jumping, anything like that. The triple jump is an extremely ballistic example of the two spiral lines working in coordination to go a long way. Broad jump, now we can have a discussion about the cardinal lines being very dominant because we're talking about a very linear type movement. But again, as soon as we start talking about efficient ways to get from point A to point B, it doesn't happen in symmetrical postures. We have to be asymmetrical or in single leg for that to happen. So we have a lot of control from this line in keeping us from collapsing down to the ground when we're walking. And then what this does for the arch. Every discussion the discussion that we had in regards to how the lateral line supported the arch, take that and magnify it, because now we actually have a complete stirruping of that arch. We actually are pulling that up into and towards the pelvis, or preventing it from collapsing down into the ground. So we have a significant component of the arch as part of this line. So with that, when we look at the issues that we run into when there's problems within the line, or issues that if we see these issues, we have to consider the spiral line's involvement. Talking about anybody that has any kind of arch problems. If they have a flat foot, okay, I think I mentioned it last time. If they get out of the pool, look like Daffy Ducks walking on the concrete, you have a spiral line problem. The opposite of that, if you have somebody with a very high arch, somebody with a very high arch is going to create some motion problems as well. It's also a spiral line issue. So we have opposite sides of that coin. If we're having any kind of conversations about the femurs being rotated, internally, externally, it's a discussion about the spiral line. The book talks about varus and valgus of the knee, but I think that needs to be expanded. It really needs to be varus and valgus of the entire lower extremity. Because if a valgus collapse of the knee is problematic, a valgus collapse of the foot is equally as problematic. And we know that those two are tied together. So if we have valgus at the knee, we have valgus at the ankle. The problem is, from a clinical standpoint, when we talk about valgus of the knee, more often than not, we're not even considering the ankle. We're talking about a collapse of the knee, we oftentimes don't even look at the ankle. It's a knee problem. We might get wild and crazy and go up and look at the hip, and it's a glute med problem. I mean, that's the history of this picture for 30 years. It's a glute med issue. It's a glute med issue. I don't know if you guys know this, but it's the gluteus medius. It's the issue there. Glute med. It's all glute med. Maybe glute med, but mostly glute med. That's the conversation for 30 years. I saw that first presentation at the first NATA meeting I went to in 1998. It's the glute med, strengthen the glute med. And then we've spent the last 30 years talking about different ways to strengthen the glute med. Either we don't know how to strengthen the glute med, we absolutely are horrendous at strengthening the glute med, or we're just wrong about it. And I think it's because we're actually wrong about this. It has very little to do with glute med. Is the glute med included? Yeah, it is. But that would be just like saying the whole reason this class is awful is because of Griffin. I mean, it's all Griffin's fault. What about the rest of you guys? You guys contribute. We can't just pick the one muscle because it looks good. Or we can't pick the one muscle because that one muscle, yeah, there's a study that shows the EMG isn't very, when we have a valgus collapse, it's because the EMG of the glute med doesn't do anything. Yeah, you're right, it's not. But where else did you look? That's the one place you put the problems. When I look for a problem, I'm going to find it. That's how we ended up with the glute med being a problem with the valgus. Collapse of the knee. It is a component, but it's only a singular component. If we remember back to those structures that attach to the IT band, just from a pure anatomy standpoint, whoever did that study didn't understand anatomy. They wanted to find a problem, and they did. They just don't realize the problem that they found. They highlighted the glute med, but they didn't pay any attention to the TFL, and they didn't pay any attention to the glute max. They didn't pay any attention to the glute minimus. We blame the glute med. And then let's, heaven forbid, we have a conversation about what that vastus lateralis is doing and how that's involved. So anytime we have a valgus anytime we have a discussion about the knees not being over the midline of the foot, either into a valgus collapse or equally as bad into a varus position, because if this is bad from a patellar tracking problem, this is creating the exact same thing, just the opposite way. It's equally bad, but we don't talk about that much. Anytime we're having that conversation, we're having a conversation about the spiral line. Shoulders that are elevated. If you remember, if we go back to the shapes, if we see shoulders that are rotated off to the side, spiral line issue. Anything going on with the head, whether it's tilted, shifted to the side, or rotated, these are all reflections of spiral line involvement in what's going on. Now, the nice thing is, if you have a spiral line issue, unless the spiral line issue is isolated to the serratus and the rhomboids, if it's not a very specific issue in the serratus and the rhomboids, if it's any other tissue in the spiral line, you have another line associated with your problem. So if you're going through and you're looking at things and you're like, you know what, I see a knee that's collapsing this way. Brandon says it's not just the glute med, it's the entire deltoid of the hip that's involved. That's a spiral line. Yes, it is, but also remember, that's also part of the lateral line as well. So you have to consider the lateral line as well. You can't just have an isolated spiral line issue because of how many of the structures are stolen from other lines as well. Mentioned this last time, we do have a little bit of a twist with this. It's like a choose your own adventure story once we get to the sacrum. Depending on multiple factors, forces can either be, at that point, forces can cross over midline for the fourth and final time and go up to the occiput on the other side, or forces can stay on the same side, not cross midline, and go up the erectors on the same side. That's kind of a choose your own adventure type situation. It's going to depend on the weight bearing status of the limb. It's going to depend on the tilt of the pelvis, what's going on with their leg length, and it's going to be a very dynamic situation. So trying to figure out which path it's taking, just assume it's taking both paths. So from a conceptual standpoint, if we think at this point that the spiral line comes up on the left erectors and the right erectors, you're probably going to be right. It's probably going to be some person. I would even say with how everything else has been laid out in anatomy trains, I would probably say it's never 100% here, 0 on the other. It's probably 60, 40, 70, 30, something along those lines. So from a conceptual standpoint, if we just understand that once we get to the sacrum, some of the forces cross over to the opposite erectors, some of the forces stay on this side, come up to the erectors. Now, instead of trying to figure out, do the forces from this mastoid go to this occiput or this occiput? They go to the entire occipital ridge. It crosses over and it stays. Portion of the forces cross over and stay on the same side. Otherwise, you can drive yourself crazy trying to figure out, well, what makes it cross over and how does it do all this? Just assume that it crosses and stays on the same side. Upper spiral line, the splenius capitis, splenius cervicus. Like we talked about, you either are starting and finishing here or on the occipital ridge. But like I said, I think it's probably a safer bet to assume that the entire occipital ridge is involved, just because you're probably not going to have a situation where it's all on the left or on the right and it's crossing over. Why is that important? Why do we need to talk about that the line starts here and finishes here? Because anything going on in the line, if we have any issues within the line anywhere, because of this orientation, even if we take it into the opposite occipital ridge, what that does for the positioning and the ability of the head to maintain its control. So the discussion that we had about the head tracking and the position of the head when we're walking and how there's not a lot of head movement, we had that exact same conversation here. It's slightly different than the interaction between the sternocleidomastoid and the splenius muscles because we don't have the sternocleidomastoid. Here we're going to get a little bit more a different type of control of rotation, but it is going to be heavily involved in how we're controlling our head when we're walking, how we're maintaining our visual horizon when we're walking. So if we have anything going on lower, it can have an effect on the head. It can have an effect on how we're carrying the head and controlling and positioning the head and how we move the head. So because of that, if we have an issue down, we have that knee issue, we have that valgus collapse, we consider that it's an issue at the deltoid of the hip, we consider all of that, and we're looking at all of that. We also have to be aware that if that person also, as we're looking at them, they also have a problem with cervical rotation, it's the same presentation. It's just a continuation of that presentation. Or if that person has this valgus collapse and they have cervical range of motion problems, that is a direct tie-in. Why is that important? Because if you spend all of your time, this person, every time they go to squat or lower their center of mass, you see this. We spend all kinds of time working on that. We strengthen the things that we need to strengthen. We re-educate them, and we get them to where they can actually do that motion, lower their center of mass, keep their knees where we want. Their knees don't collapse. We got them where they jump and when they land, and their knees aren't collapsing. We've done a lot of things. It's going to be a long process to get them from here to here, but we get them there. We do all the things that we're supposed to do. We high five them. We send them out the door. We think, wow, we did a wonderful job. It's just like the end of season 1 on Stranger Things. I just started season 3 last night. It's wonderful. Just like the end of season 1 on Stranger Things. The only reason you had season 2, the only reason there was drama in season 2 was because they didn't close that portal. They didn't close that gate. They got rid of all the issues, but they didn't get rid of the problem. So it's the same thing here. We take care of this. We think we've done a good job, but we never address the cervical issues. We've still left a little bit of that problem on board. And what does our nervous system like to do? Whatever normal is, it likes to stay normal. So if we take care of the lower part of this, but that person still has a cervical range of motion issue, and it's still showing us that we have some cervical issues, and we still have some stuff going on in that line, and we didn't actually fully resolve it, the body's going to go back to what its normal is used to being. And that normal is, I have cervical issues and I like it when my knees do this. Well, we've taken the knees away. It's not doing this anymore, but we're going to slowly revert back to that because we didn't completely resolve the situation. We left a little bit of it up in the neck. One of the things I didn't understand for the longest time was within functional movement systems, within their SFMA, first thing they look at, the top 2 of the SFMA are cervical patterns, flexion, extension, rotation. It took me forever to understand, and for the longest time I disagreed. If somebody had a cervical issue, we always address that first. I don't necessarily know that I completely buy into that approach, because why does it always have a priority over everything else that's going on? But I am on board with the understanding that if somebody has a cervical issue, it needs to be addressed with whatever else we see. We can't fix a valgus collapse at the knee knowing that the spiral line has a heavy influence in the neck and then leave somebody with limited cervical range of motion, because that issue is still there. It's going to go back to normal. That normal that it likes is here. So all the hard work that we did to fix this, we didn't fully fix it, and there's a high likelihood it's going to come back. Upper spiral line. For quite a while now, kind of the understanding in the rehab world is if you have a shoulder problem, you have a neck problem. You need to consider the shoulder and the neck as one function in you. And I completely agree with that. However, if the common perception is if I have a right shoulder problem, we need to be concerned with the right side of the neck. I don't buy into that thought process. Do we need to consider the right side of the neck? Yeah, we do. But if we think about it from a spiral line standpoint, because the right side of the neck, that's lateral line. We also have to consider spiral line. I know that my right scapula is tied to the left side of my head. So if I have a right shoulder problem, I have to consider the neck on the opposite side. I can't just consider the neck here. If I only consider the neck on this side, yeah, I'm considering the lateral line involvement in the shoulder. Need to consider that, but I also need to, I can't be so short-sighted that I forget the left side. I forget the tie-in of that spiral line. So that tie-in from the splenius down into the rhomboid, down into the serratus is extremely important. If you were to take away the scapula, so like if we were to do a scapulectomy, we're going to remove your scapula. I don't know if it's ever been done. I don't know if it should. But from a hypothetical standpoint, we're going to remove your scapula. This fascial connection still takes place. The rhomboids stay connected to the serratus. The connection between the rhomboids and the serratus is more robust than the connection of the rhomboids into the scapula or the serratus into the scapula. So if you were to remove the scapula, that connection still takes place, almost like it's one continuation of a muscle instead of two. So what ends up happening is, from an anatomical standpoint, because they attach it to the scapula, this is one muscle, this is another. But when you start to look at these tissues, if that scapula were gone, you can make an argument that that's one muscle. It's not, because we all have scapulas. But we have to understand that that connection into the scapula is not the main connection here. The main connection is from serratus into rhomboid. So why is that important? We have people with rounded shoulders, right? And what do we try to do? Try to strengthen the rhomboids. Well, if somebody can't fully extend their knee, do we just strengthen the distal quad? Or do we try to work on the whole quad? We work on the whole quad. So if we have somebody with a scapula with a rounded shoulder situation, if we're focusing on the rhomboids, yeah, that's a correct focus, but we have to expand our focus and consider this whole connection, what that does, because the scapula is just stuck in the middle of that connection. It's going to go wherever the serratus, wherever the rhomboid directed to go. So we have to consider that. From a manual standpoint, you'll find people all the time that if you get to put your hands on them and you start working through here, you're going to find some trigger points in the rhomboids, and they're very prominent. I would encourage you, if you find a trigger point in the rhomboid, lay them on their side, have them put their arm over their head, get into the serratus. You're going to find some stuff there as well. Because if there's an issue here, there's going to be an issue out of the serratus. And again, oftentimes, clinically, we'll do the right things. We'll find these trigger points. We'll address the trigger points in the rhomboid. We're doing the right thing, but we have to take that next step and explore out into the serratus as well, just to make sure that we're not leaving some stuff there that's going to take us back to that normal that we don't want to be at. The ASIS, ASIS is unique just within, or if we look at the ASIS, if we think about everything that connects to the ASIS, we have the transverse abdominis, the external obliques, the internal obliques. We have the gluteus medius, the TFL, the sartorius, and the iliacus, all that attach directly to the ASIS. Then that's the 7. The 0.5, you have the rectus femoris that attaches at the anterior inferior iliac spine. It's not a direct attachment to the ASIS, but because of its line of pull, it does have a heavy influence in that area. So because of the number of muscles that attach into this area, if we look at the line of pull, the ASIS, that area is exposed to all kinds of different stresses, pulling it in a lot of different directions. So if we have again, just from a consideration standpoint, if you have any trigger points in any of these muscles, one of the things we have to consider is the ASIS. Remember, where the tendon attaches into the bone, that's a very sensory rich environment. So we have to consider the ASIS from what it does from a sensory input standpoint, what that contributes in regards to the line of pull, what that does in regards to the nervous system. So if we have issues in any of these tissues, it's also a good idea to go in and make sure that the ASIS is the way that it needs to be. How do we do that? Well, first and foremost, the tissue over the ASIS needs to move. You have to be able to slide and glide that tissue smoothly and efficiently in all different directions. If the tissue is locked down and it doesn't move, you're going to have problems. Anytime we talk about very superficial bony prominences, ASIS, the spine of the scapula, greater trochanter, tibial tuberosity, Gerdy's tubercle, the spinous processes of all of our vertebrae. If the overlying tissue doesn't freely move in all directions and it's locked down to that, you're going to have problems with that. So we have to make sure that the overlaying skin, we have really good tissue mobility with that. We also have to consider the periosteum, because anybody's ever had a hip pointer, they fall, they get hit. ASIS is very superficial. Even though all these things are attaching to it, there's still a portion of it that is just directly below the skin. You can have an injury to that from a direct blow. That's going to be very painful. Well, why is it very painful? Because it's a direct blow to the periosteum. The periosteum is a sensory-rich environment. It's going to be painful because you have a lot of free nerve endings in that periosteum. So same thing, you have all these different lines of pull going through here that can affect what's going on in that periosteum. So even if the tissue is able to slide and glide appropriately above that, we might need to go a little bit deeper and consider the periosteum. Now, when we start talking periosteum, our mechanism to address the periosteum, we're very limited in our in actual tools that we have to do that. We can do it from a Graston standpoint, or we can do it from a dry needling standpoint. If we go even further out on the fringe, red light therapy, laser therapy, you want to go old school, ultrasound can get to that, but we have to consider the periosteum, especially if somebody actually has had a hip pointer type injury. Unfortunately, somebody has a hip pointer type injury. What do we do from a rehab standpoint? Minimal. We pad it, we protect it so they don't get hit again. And then because everything, somebody gets a hip flexor injury, everything in this area, what happens? It kind of contracts down. Everything shortens up because it hurts. And it's protecting that. We further protect all the right things. And then what we try to about the only thing that we do from a rehab standpoint for this injury is we work on stretching out the quads, we'll stretch the hip extensor, we'll stretch the hip flexors. And that's about it. And again, I'm not saying that that's wrong, but if what we do is we stretch out the rectus femoris and we stretch out the iliacus, that's wonderful. What about the other 5.5 muscles that influence this area? So we have to, even though it's a relatively low-level injury, it's a very painful injury. We have to understand that this isn't like an injury where you sprain your ankle, and if you send them back too early, there's a risk of creating more damage. Somebody gets a hip pointer, they go back, is that hip pointer going to get even worse? They get hit again, it's going to hurt more. The likelihood of you getting a direct blow and fracturing that, I can't say I've ever seen that. So it's not like they can make it worse. It's going to hurt. It's one of those things, it's going to hurt more. But are we making the situation worse? Not from a tissue standpoint. But we also have to consider, it's not just from a tissue standpoint. What about from a sensory input standpoint? Because if that person's gotten a hip pointer and it hurts, and we know that everything is contracted down, we're not going to do more damage to this. But if everything's contracted down, what's that going to do when I'm trying to run, plant, cut? It's going to change a lot of things. So we need to address this, not because I'm worried about doing more damage to ASIS, but because we need to make sure that everything, these 7.5 tissues that attach here are able to do the things that they need to do so that those lines aren't affected. And if we look at these, we're talking about lateral line, we're talking about spiral lines, we're talking about single leg stance. And as soon as we have a conversation about single leg stance, we have to have a consideration for what happens when our foot interacts with the ground, ankle sprains, knees, stuff like that. So it's not an issue from the actual injury, but we have to worry about what happens if we don't address those issues appropriately down the line. Lower spiral line. Ooh, where is it? I brought my fancy jump rope in today. I was the LaBelle Elementary jump rope for heart champion in 1987. I can't demonstrate there and go ahead and the ceiling. But I was kidding. I didn't win jump rope or whatever it was. We think about the spiral line. We know the spiral line loops around the bottom of the foot. It goes behind the base of the fifth, comes up the first metatarsal, first cuneiform. So we have the anterior tibialis, we have the peroneus longus. It wraps the bottom of the foot, and then it basically fits just like this. So this is our lower lateral, this is our lower spiral line. So if we think about that, if we think about what that does for whether the foot's inverted or everted, we have to have a strong consideration for that. If my foot's inverted, we now have a very supinated foot. We have a high arch. If my foot's everted, now we're talking pronation, we're talking a valgus collapse. So if we think about what's going to cause that to evert, that is going up the perineals up into the biceps. Oh, I'm going to drop my spiral line. So if we have too much tension here, that's going to create a force vector that lends itself to an eversion type mechanism of the foot, which then sets the knee up for valgus collapse. How many people have tight hamstrings? When we think of tight hamstrings, do we ever think of what it's going to do in regards to the foot and an ankle sprain? No, we don't. When we have somebody with a collapsed arch, somebody with a pronated foot, do we ever think of the lateral hamstrings? Not too often. Now, as part of our assessment, we might do a straight leg raise and be like, oh, hey, look, the hamstrings are limited. They're screaming at you, my hamstrings are limited. Now, if you address the hamstrings and if you work that out and you address things, is that going to all of a sudden miraculously give them a normal arch? Probably not. But it's one component of that solution. We have to consider that. Just like we talked about before, though, the anterior tibialis, peroneus, the peroneus longus, at best, those muscles are this big. They're not strong muscles, they're fast muscles. So we need muscles that turn on and turn off really, really quickly. We can't, if we're going to focus on isolated type exercises, that's fine. We have to understand that's more from a sensory input and a blood flow standpoint. Not necessarily we're making them strong. We need to make these muscles fast and responsive. The tie-in to big toe extension, it is worth mentioning here. If somebody has a problem with their big toe, they're lacking big toe extension, somebody that has turf toe. That because of the proximity of this attachment point at the base of the first, that can be influential in what's going on with the spiral line. It can change things up just a little bit, even though it's not a direct representation or a direct part of this line. Anytime we have anything going on at the hip, you have that person with the snapping IT band or IT band tendonitis or any of glute med weakness. We consider that for the hip and what that does for the pelvis. We also have to understand it's going to have a direct influence on what's going on with the foot. So again, when we think of the lines, when we think of the fascial lines, I would encourage you not just to think of them as a collection of these muscles are in this group, But if we see something in the line, we have to consider adaptations, ramification, changes everywhere else in that line. So if we have somebody that has a glute med issue, and let's just say we're in line with what they've been talking about since the 80s. Somebody has a glute med issue, has an IT band issue. We have to consider a lateral line as being affected, the entire lateral line. We have to consider the entire spiral line being affected. So we have to consider what that's going to do with the foot. So this is also one of the reasons why somebody has an ankle sprain. We look at the strength of the ankle. We test ankle dorsiflexion, we test plantar flexion, we test inversion, we test eversion. We'll go through, we'll do a manual muscle test, we'll get all that stuff. That's wonderful. We need to have that information. But when was the last time you did a manual muscle test of the hamstrings? Because tons of research out there show you sprain your ankle, where you see the biggest loss in strength isn't in the anterior tibialis or the peroneals. The biggest loss of strength ends up being in the hamstrings. So if you have an ankle sprain, you've got to consider the hamstring. And when I first came across that, I came across one article, like, okay, that's interesting. And then I came across like 7 or 8 articles that supported that said the same thing. I'm like, okay, that's a lot of stuff. Research. It's research. What's that do from a clinical standpoint? So I was curious, and I'm like, all right, hey, every ankle sprain that comes in at our West Edge facility, you get anybody with an ankle, anything, a foot, anything, do the things that you normally need to do, whatever you think is clinically appropriate to look at. But I want you to also test the strength of the hamstring. We have a nice little handheld dynamometer, gives us the exact number. I want to know what that strength is and if there's a difference side to side. And it took them all of about 4 patients. They're like, yeah, every single one of them, whichever ankle we're dealing with, hamstring on that side are significantly weaker than the other side. So I'm like, okay, maybe, because I'm trying to now prove the research wrong. Maybe what we're seeing is they sprain the ankle. I'm playing all this out. They sprained their ankle. They did whatever they did to their ankle. It's because this entire limb's weak. So when we test the hamstrings, it's weaker because the whole leg's weak. It's not the hamstrings are shut down or the hamstrings are, this is a ripple effect from what we've seen at the ankle. The ankle is because just the whole leg was weak. So, okay, now guys, I need you to do one more thing. After you test the hamstrings, I want you to test the strength of the quads. And what they found was, yeah, quads are good. Quads within 10% on each side, but hamstrings, significant difference, which then tells us that there's a significant connection between that hamstring and the ankle. Where does that come from? It comes through the spiral line. So anytime we have anybody in a walking group for any reason, we've always paid attention to, we need to address the gastroc, the soleus, we need to address all the inverters, everters, dorsiflexors of the ankle, but we also have to address the hamstring. We have to work on hamstrings. If we don't, we don't address the hamstrings, we can do all the right things down below, but as soon as we get them back and start doing the things that they need to do, the hamstrings aren't the way that they're supposed to. It's going to devolve all the work that we just did. It's going to take away all the good work that we just did. We have to think a little bit higher with that. Lower spiral line, the 4th hamstring, the short head of the biceps. So the short head of the biceps comes into the linea aspera of the femur, on up into the adductor magnus, and attaches into the ischial tuberosity. So we have the long head of the biceps femoris is formerly a part of this line that takes us from the lateral knee up into the posterior ischial tuberosity. But we also have the short head of the biceps, which blends into and transmits force into the adductors, which now takes us more anterior on the ischial tuberosity. So essentially, the ischial tuberosity is extremely important when it comes to the spiral line. Transmits force on up into the sacrotuberous ligament, and then on up into the erectors on the same side, crossover erectors on the opposite side. So the ischial tuberosity is extremely important. Why do I mention this? If you have somebody with an ankle sprain, we keep coming back to ankle sprains because ankle sprains are the cornerstone of athletic training. You have somebody with a knee issue. We know that the spiral line's involved. If they sit all day in a chair, we know tissue quality is going to be off just because of ischemic compression. Tissue ischemia doesn't do anything good. Tissue ischemia always creates problems. It always compromises cellular metabolism. It always compromises cellular health. Essentially, the easiest way of thinking about it, if you have tissue that's ischemic, instead of all the cells in that area operating at 100%, at best they're operating at 75%. So you've automatically pulled down what that area is capable of, which means from a cellular standpoint, if we know that I have an ankle sprain, and if we know this area is affected, the rate in which that tissue is able to heal is going to be significantly slower because it's only functioning at 75%. We're slowing down the healing process. Somebody has a hamstring injury. We know that there's issues at their ischial tuberosity. They're very tender through that ischial tuberosity. We know that this area is going to take a little bit longer to come around because, especially if they're a high school athlete or a college athlete, or they spend all day working in an environment at a desk because they sit on a tissue all day long and they compress that. So we know that that's going to slow things down. If you have an ischial tuberosity, that's part of what's going on. We know that the healing of that is going to take a little bit longer unless we address the tissue ischemia. How do we do that? We have to have some conversation of limiting when people sit and how people sit. We've had a couple patients over the last couple of years where they've actually had avulsions of their ischial tuberosity, where that long head of the biceps, they pull that chunk of bone off. It's a very simple surgery. They make a nice about 4-inch incision in the lower butt cheek. They retract that and they put some screws in there and they hold it down. It's a very simple surgery. It's a very easy surgery. So easy, I think I could do it. I have the DeWalt at home. I am pretty good with wood screws. I could probably do that. Nobody will let me. I don't know why. But anyway, easy from a surgical standpoint, very strong from a repair standpoint. We don't have a lot of consideration. It's a very frustrating situation to deal with because it literally takes forever. Why does it take forever? Why is this tissue different than everything else? Because the tissue ischemia. You're starting out at best operating at 75%. So one of our recommendations with these patients, if you have this, if you want to actually, one of our priorities with these patients, we have to improve tissue health of this area because we know tissue health is compromised. So we have to start out aggressively addressing tissue health. One of the things that's been the most impactful and had the most impact on what the patients are feeling and experiencing is instead of sitting down, lay on your belly or stand up. Don't sit. Find a way to not sit. And with these patients, surprisingly, the patients that we get with this, they're not young, healthy individuals. They're in their late 30s, still somewhat active, work a desk job for 8 to 10 hours a day, and then they like playing soccer, they like playing basketball, they like doing something else on the weekends after work. Eventually, the tissue gives out. So I've never had a high school kid, knock on wood, never had a college kid with this. It's always been that older population. The conversation I have with them, like, listen, you're a grown-up. Talk to your boss. Get a stand-up desk. Tell them it's going to be for the next 8 weeks, and then you can go back to sitting down. You've got to find a way. Don't sit down. At work, you're standing up or you're laying on your belly. Get a stool where you sit on the opposite side, but do not compress that. And what we start to do is we start to take away the times over the course of the day where this tissue is compressed in an ischemic situation. Now, the hard part is driving and sitting in a vehicle because you can't stand up and drive and you can't lay down and drive. So that's not negotiable. But everything else, you're standing up or you're laying on your belly. You're not sitting on that butt cheek. And when we do that, we really start to see a change. We see an improvement in the incision because this is also an area that's very slow to heal. Why is it slow to heal? We're constantly sitting on it and compressing. How long would it take the incision after an ACL to heal if we constantly spent 6 hours a day with our knee on the ground? It's not going to heal. This area doesn't heal. So stand up, lay down, do not sit on this at any point of the day, and limit it. Try to limit it to less than an hour that you're compressing over the course of the day. That's had more of an effect on the clinical outcomes of these patients than anything that we can do clinically with them, because we're actually changing tissue quality. So we have to understand, if you're dealing with a hamstring, those are the issues when you have an avulsion of the ischial tuberosity. Like I said, I've probably seen 4, maybe 5 total in my 20+ year career. You're not going to see this very frequently. What you guys are more often going to be interacting with is a hamstring issue. If you have a hamstring issue, same conversation I just had, have to address the tissue quality of the ischial tuberosity. We talk about the lower spiral line. We talk about the valgus collapse, the internal rotation of the knee. For 30 years, blamed. For 30 years, we blamed the glute med. It's not just the glute med; it's the entire lower spiral line. It's the pelvis, it's the knee, it's the foot. If we have valgus collapse at the knee, we have valgus collapse at the ankle. This isn't bad, and this is good. These both have to be considered equally bad, because if my arch collapses and I can't control my foot, and I'm landing, whether it's when I run or when I jump, what ends up happening, that foot hits the ground, it continues to collapse. And look what my knee does. My knee wants to travel inward. It's going to. So if we're going to have a conversation about the knee, we have to have a first and foremost conversation about the foot, and making sure that the foot isn't continuing to drop until it hits the ground. So we have to have that conversation. It's not just a strength issue. The biggest and strongest muscle of the lower spiral lines is the long head of the biceps, and it's not a big, strong muscle. These muscles, we can't rely on strength. That's why none of the strengthening protocols for 30 years have worked. It's not a strength issue. This is a timing issue. The problem is we've identified the right structures. We have identified the right area. Heck, even if we, from a glute med standpoint, if we would stop trying to strengthen the glute med and actually start working on the glute med being a quick muscle and a responsive muscle, we would probably see some impactful changes. But we're still stuck on, let's work on resisted abduction. It's not a strength issue. These are not strength muscles. These are timing muscles. These are muscles that have to turn on and turn off quickly in a manner. They have to be able to turn on and turn off quickly so that the foot can be where the foot needs to be. So the knee can be where the knee needs to be. Valgus collapse of the ankle, same problem. Unfortunately, we don't give it the same consideration. You see somebody with a foot that collapses, oh, you just have a fallen arch. It's not that big of a deal. If you have a fallen arch, if you have a fallen arch, your knee is going to end up in this position. And we know the things that can happen when your knee ends up in this position. You have a fallen arch, does that mean you're going to tear your ACL? No, it doesn't. But it also means that every time you step down and take a step when you're running, you're exposing your knee to those forces. If I expose my knees to those forces every day, or I buy a lottery ticket every day, odds are I'm not going to win the lottery before I hurt my knee. Otherwise, I would have won the lottery already. But they haven't given me $1 million yet. So we have to understand, if we see a pronated foot, it's not just about the foot. If we see a pronated foot, that knee is going to do this. Guaranteed. We are putting there. I'm not saying that you're going to hurt your knee, you're going to do anything to your knee. But at some point, if you're routinely doing this, at some point, things might go sideways and your risk of a knee issue is going to be rather high. But again, oftentimes we just see that foot that pronates and it's just a collapsed arch. We don't give it any consideration above that. We have to consider more.
So how to make them react to like fast response other than?
Oh man. When we get to the lab, we're actually going to talk about this. It has to, it's not with foot and ankle stuff. We have to integrate other things. But yeah, when we get to the lab, we'll talk about that. Fascial tie-in, like I said before, it kind of shows us something's going on in that transition between supine and prone, the segmental rolling. But where we really start to develop the spiral line is a quadruped. Quadruped, sitting, kneeling, and then standing. And we really start to develop the spiral line in those locomotion patterns. So crawl, rooting, and walking. It develops a little bit later because it's not one of our cardinal lines. It involves dissociation. So from a sensory input, it takes the nervous system a little bit longer to kind of work things out and figure out how to work with this line. It's not something that we just start and can go to town with on day one. Any questions about the spiral line? So we've talked about the 4 cardinal lines. We've talked about the spiral line. We have our functional lines. We're going to talk about those. Functional lines are a little bit different. They don't extend all the way down to the feet, all the way up into the neck. It's really more trunk and pelvis. We have our deep front line. We have our arm lines. So deep front line connects everything. Functional lines, it's all about the function of the pelvis and the trunk. Arm lines are all about the function of the arms. So at this point with the spiral lines and the 4 cardinal lines, I think it's a good place to consider some injuries that we commonly see. If we look at it from an acute standpoint, we see lateral ankle sprains, ACL tears, tibial tuberosity avulsions, ischial tuberosity avulsions. You can have ASIS avulsions. I think it's important to start looking at these and considering the fascial lines that are also impacted with this. If you sprain your ankle, we have a basic lateral ankle sprain. We have to consider what that's going to do, the ripple effects that's going to have throughout the lateral line, throughout the spiral line. Because again, if prevention is one of the domains of athletic training, we can't act surprised later on when these issues develop. Physiology, we know from a physiological standpoint, the cascade of things that are going to happen. We know from an injury standpoint, from a movement standpoint, the cascade of things that are going to happen. We know with a lateral ankle sprain, if you damage those tissues, we immobilize that area. We know that there are going to be ripples up into the lateral line and the spiral line. If we don't proactively start addressing those from day one, we're creating problems. We are not preventing injuries because we know that there's going to be negative ramifications within both of those lines. It's going to happen. It's not, is it going? It's guaranteed we're going to see these issues. You sprain your ankle, it's guaranteed we're going to see hamstring issues. We effectively rehab that ankle. We send them back to soccer. They strain their hamstring and we spend the rest of the season dealing with their hamstring. That is literally our fault. They had an ankle sprain. We addressed the ankle. We didn't address the hamstring. We returned them back to play with a hamstring that doesn't know how to be a hamstring now. And what happens 2 to 3 days later? Ow. And now we're trying to deal with that. We caused that. Not soccer, not the athlete. We caused that because we didn't effectively, we stuck our head in the sand and we treated an ankle. Think about how many times an athlete we return from one injury and they, within the next month, they suffer a different injury. That's on us. That's on us because we didn't look anywhere other than the ankle. We didn't look anywhere other than the knee. We didn't consider all these other things. It's there. It's right in front of us. We know that this stuff is going to happen. We know you sprain your ankle, your hamstrings are going to get weak. What do? Day one of an ankle sprain? Can you do knee flexion? Can you do resisted hamstring curls on day one after a grade 3 ankle sprain? Yeah, it's not going to do anything. Because what all can you, grade 3 ankle sprain, what all can you do on that person for their ankle? You can do some soft tissue work, you do some lymphatics. We need to do all of that. But there's not much else you can do. Okay, so 15 minutes, you're out the door. Wonderful. take 25 minutes. We just did our soft tissue stuff. Now we're going to put some stuff on the bar and you're going to go do some hamstring curls. Go find the resistant knee flexion machine. Go until your hamstring cramps up, call it a day. That's going to be better than not doing anything with that. We can start that day one and we can prevent that from day one. So we have to, when we have these acute injuries, we have to consider the entire line and what's going to happen with those. Our overuse injuries, which we talk about an overuse injury, it's really, overuse is not a problem. We call it overuse because we don't really have anything else to call it. We needed something to call it, so overuse sounded good. We could call it chronic, but either one, basically, we don't know what it is. So when we have an overuse injury, basically, we call it overuse because anything else sounds like we're inept at our jobs, but we really don't know what it is. And that's okay. We just need a word for it. So anytime we have a situation where it's a non-acute situation, I don't like calling it overuse. We can't call it chronic. So we have our acute issues, we have our acute injuries, and we have everything else. So we have our acute problems, and then we have the other things. So we start talking about the other things that take time to develop. Remember, when we see these non-acute type injuries, we're seeing breakdowns at the weakest link in the body. So when we see that person that walks in with anterior knee pain, patellar tendonitis, tibial tuberosity, stress fracture, we see that. Yes, we need to treat that, but we also have to understand that's the point in the fascial line that's the weakest link. We can't just address that patellar tendon. We have to address the entire rest of that superficial front line, because without an actual mechanism, we're going to break down at the weakest link in that fascial line. If all we do is address the patellar tendon, the issue is still there. The issue that caused that response at the patellar tendon, it is still there. All we did was address and turn off those indicators that there was a problem. So we have to consider, anytime we have a non-acute injury, we have to expand our thinking to think about what other fascial lines are involved in this and where do I need to look. So you have somebody with an anterior knee issue, we have to consider the entire superficial front line. You have somebody with an IT band tendonitis, we've got to consider the lateral line, we've got to consider the spiral line. Somebody has low back pain, first and foremost for consideration, it's got to be the spiral line and the superficial back line. Somebody's coming in with neck pain, good luck. We got to consider all the lines because the neck, all the fascial lines pass through the neck. Somebody has a hamstring issue, you got to consider the spiral line and the superficial back line. So again, not saying that the things that we're doing for these not saying that the things that we're doing for these issues are wrong. We're doing a lot of the right thing. But if we have to understand that if we see an IT band issue that has progressively gotten worse over time, if we see that, that's an indicator. It's like the warning light in your car that comes on. It's getting cold out. Depending on what your vehicle is, you might get a warning of low tire pressure because you have to take the summer air out, put the winter air in. But you might get that indicator that there's a tire pressure warning. Way back, the first truck I ever got was my dad's. It was a 1987 Ford F-150. And on the dashboard, I always wondered why he had a black strip of electrical tape on the dashboard. And then one day I was curious. I was like, I wonder what that is. And I took it off and there's this big red light underneath. It was just the general warning light. He's like, yeah, it's a warning light. He's like, I don't know what it's for. He's like, we've looked at everything. We can't find anything, but the warning light's still on. It just meant that there was a warning. We need to consider something with the truck. Couldn't figure it out, so he just covered it up. Drove the truck for another 10 years, no problem. But now it's a little bit more specific. It's not just you have a general warning light, there's something going on in your body. That's like a fever. When we have IT band tendonitis or an IT band issue, that's this very specific warning light, low tire pressure. Something's going on in that line. Something is going on when you have an IT band issue. We know something's going on in the lateral line or the spiral line. We have to address, we first and foremost have to go put air in the tire. We have to get this taken care of. But then we need to make sure that there's not a leak in the tire. We need to make sure that there's not something else that's causing this. We have to look at everything. We have to make sure that there's not something else in the lateral line or the spiral line that's going to continue to give us that warning light. Oftentimes from a clinical standpoint, though, what we do is we see an IT band issue and we deal with the IT band. And we don't know why it won't go away. We don't know why it keeps coming back, and we get frustrated. We get frustrated because when we get frustrated, it's because we're only thinking about that thing in isolation. We have to consider the rest of the lines, all of the lines that are involved. All right, any questions?